psoriasis is a type of a skin condition. It falls in the category of an autoimmune skin disorder. So we all know that we can have so many skin ailments. All of us at some point of time have suffered from some of the other skin conditions. So there can be infections in the skin. There can be what we call as allergies or eczema in the skin. There is a very particular specific entity called autoimmune skin disorders, wherein the immune system of the body starts functioning against the body. We call it immune attack against the self. So that produces these different types of autoimmune skin conditions. And among those many conditions which come in this category, psoriasis is one of the most common autoimmune skin conditions that we see in the general population. That there can be several different reasons for skin problems that we see. So infections can be fungal infections, which we see very common, called tinea. There can be infections in the skin, which we call cellulitis, or where pus fills up, we have boils, carbuncles, furuncles. These are all infectious reasons. That is when some of the other infectious microorganism or germ attacks our skin, and that produces either localized lesions or short-lasting symptoms which respond well to any antibiotic. Psoriasis, on the other hand, happens because there are certain immune cells in the body which get aberrantly activated, and the damage starts from the first layer of the skin called keratinocyte. And this skin inflammation which happens, it produces the various symptoms of psoriasis. And psoriasis, mind you, does not remain limited only to the skin. It can involve your nails, it can involve the scalp, it can involve the eyes, the intestines. So it is actually a multi-system autoimmune condition. And also your joints, which if it involves, is called psoriatic arthritis. Generally, the symptoms of psoriasis start off very mild. So you could have a small patch which could develop probably in the scalp, behind your ears, or sometimes on the tips of the fingers, at the elbows or the knees, in the chest, abdomen, or on the back, sometimes between the buttocks. The characteristic of this patch will be that it will be more in the winters and rainy season. It will be bright red to begin with, along with some whitish scales. And if you scratch it, it would bleed from underneath. Another symptom for these are that these patches are quite itchy. So the patient will describe them as like this itchy white patch they have got, which keeps coming and going. Now, this is the most common type of symptom that we see in psoriasis. There are certain uncommon symptoms in psoriasis, which we call specialized or specific types of psoriasis, which is called guttate psoriasis, where you would have small water droplet-like lesions, which could involve the entire body. There could be something known as a pustular psoriasis, where you could get pus-filled boils at different parts of the body, which is very commonly mistaken as an infection. So these are very different types of symptoms which you get in the skin. So importantly, every patient with psoriasis, their nails should always be examined, whether it's the hands or the feet, because these patients will have some pitting, that means some small depressions in the nails. Their nails might start to break off from the edge. And very commonly, these patients are told that they have a nail infection, which is a fungal infection. And actually, that is not a fungal infection. That is psoriasis involving the nails. Generally, since it is an autoimmune condition, there is a theory which we use to explain psoriasis. So what happens? All of the patients who have psoriasis, they have some of the other genes which they have acquired from their parents or their family members, which put them at risk for this disease. That is why you will see that many patients with psoriasis, some of the other family member, usually the first or second degree relatives, could be the father, mother, sister, brother, some second degree cousin, they would have a history of having similar condition. So these genes are what put us at risk for the disease, but you can't really do something about those genes. You can't modify them. So that is called a non-modifiable risk factor. Those people who have these genes, not everybody ends up having psoriasis. Only a small section of those patients will have psoriasis. And this is when the second hit hypothesis or this theory comes into play, that anybody with this gene, if they have some environmental or insult from the host, for example, if a patient who has a mother who has psoriasis is an extensive smoker, he is at risk for getting psoriasis. Or suppose you have this young boy who is very obese, is not eating well, has a lot of unhealthy food items in his diet, doesn't exercise, again at risk for acquiring the disease. Or suppose somebody has vitamin D deficiency, that is another risk factor that puts you at risk for this disease. Other factors which are implicated, but there is not very convincing evidence, is pollution. So if there's a lot of outdoor pollution, you could get this disease. That is why it's seen more in the urban environment where there's a lot of pollution. So poor air quality could be a risk factor. if you have been having recurrent infections in childhood, sometimes you're having a sinusitis, then there's an infection in the lungs, some UTI, some urinary infection, some diarrheas off and on. So a child through his young age who's been having repeated infections, they are also at risk for acquiring this disease. It's important to remember there is no blood test or some imaging or some X-ray, MRI which can diagnose psoriasis. No, it is a clinical diagnosis. By clinical, I mean the history that you give to your rheumatologist, the symptoms, how they began, how they evolved, how long you've been suffering, is there a family history? So that coupled with the examination, that is when you present to the rheumatologist, they will examine your entire body in detail. So many a times we ask the patient to undress themselves and look for specific sites behind the ear, in the scalp, sometimes between the buttock cleft and behind the thighs where they probably are not able to look at the patches themselves. So a detailed examination of the skin along with the history helps us make the diagnosis. That is usually enough to diagnose this condition. Sometimes if we are slightly suspicious that there could be another ongoing infection which is present along with this psoriasis, we might do a skin biopsy. Occasionally we need that, but that is usually not needed. So to confirm the diagnosis of psoriasis, skin biopsy is not needed, only except in 5% cases. Another important thing, any patients with psoriasis, when they come to us, because we know that it can involve the nails and joints and eyes, we always examine the eyes, the nails, look for any joint swelling or ask them for any symptoms like a back pain, which is more in the morning, so that we can sometimes identify the earlier subtle findings where this disease has started involving organ systems beyond the skin. A lot of people have a lot of myths about psoriasis. So people think that this is an incommunicable disease. So if one family member has psoriasis, they will isolate that person, tell them to sit alone. They will not eat with them, not let them go out socially. I have a patient who came to me saying that he wanted to join swimming, but because he had psoriasis, the swimming pool manager said that no, this is a communicable disease, you can't swim. So first thing, it is not communicable. And second thing, with treatment, a patient of psoriasis can look absolutely normal. I mean, if you look at the patient, you might not be able to figure out that actually he's having this disease if he's on proper treatment. Now, when I talk about treatment, what treatment we give in terms of whether we apply some topical ointment, some shampoos, oral medications, depends on a lot of things. How much of your body skin is involved? Which part of your body is involved? Secondly, are you having any other symptoms beyond skin? So is there an eye, nail, joint involvement? Putting all these things together, we will devise a treatment plan for the patient, and this treatment plan will be directed towards correcting the autoimmune dysfunction. That is the autoimmunity which is building up in this patient's body, which is causing the inflammation. We will try to target that so that at one go, we can control all the different symptoms of this. Most important is to keep a check of your body surface. That is, identify even the smallest patches which might be missed if you don't look carefully. So always keep a check of the scalp, behind the ears. You can use a mirror if you want to. The lower part of your abdomen, the buttocks. These are the sites where you might miss some patches. Second thing, if you are getting a new patch while you're on treatment, review with your doctor, review with the rheumatologist. They might need to change your medicines. Third thing is that if you are on regular medications, still your patches are not controlled, that means something is not working. The therapy needs to be changed. Vitamin D levels have to be regularly checked and supplemented. You can sit in the sun. Sitting in the sun is not contraindicated for psoriasis patients. That only helps your symptoms. It doesn't make them worse. And of course, very important, if you have psoriasis, generally the skin tends to be very dry and scaly. So use liberal amounts of moisturizer. You could use petroleum jelly like Vaseline. You could use coconut oil. Some patients like using natural things like aloe vera. So all of those things really help. Whatever face wash or shampoo that you're using, it should be salicylic acid based so that any sort of excessive scales which might form because of psoriasis, they're taken care of. The first thing is, if your skin psoriasis is not controlled properly, if it's been persistent for several years, in future, it could lead to carcinoma or cancer of the skin. Secondly, if you have psoriasis and it has spread beyond the skin into the eyes, you could have what is called uveitis, where there will be sudden visual disturbances in the eye. One of the eyes could get very red, very painful. And sometimes there is a specific type of uveitis, which we call posterior uveitis, where there will be no symptom, but patient will have sudden loss of vision, which is quite vision threatening. Other complications include they could have arthritis of the spine, so their neck could get deformed, the lower back could get deformed, they might develop a hunchback. Then they could also have IBD, which is inflammatory bowel disease, wherein they have swelling in the intestine, which causes hemoglobin falling, their severe abdominal cramps happening. They could pass blood or mucus in stools, and they will require then specific therapy for that. Another important thing, most patients with psoriasis, they have ongoing cholesterol abnormalities. They might have blood pressure, hypertension, that is called diabetes. They would have BMIs towards the higher side. Some of them might be obese. And all of these comorbidities, along with the ongoing psoriasis, puts them at high risk for heart disease and stroke. So controlling psoriasis becomes even more important to prevent these complications.